Thank you very much. I am delighted to join you this afternoon. I would be, I admit, more delighted if I were not suffering through January in Toronto. It's a particularly cold one and a snowy one. I do wish I were in the Gulf, and for many reasons, I wish I were joining you in person. I trust we will in the near future. It's wonderful to be a part of this expert faculty, and I'm going to hang on to Tobias's words that we are now reaching the endemic phase, that we will beginning to return to something that resembles normal. If I've done this correctly on the Zoom call, you will see a rather complicated title there. I've been asked to speak about, as you see, treatment of mild moderate asthma, ICS LABA maintenance and reliever therapy approach versus maintenance treatment plus short-acting beta-agonist SABA as a rescue. Oh my goodness, that's almost all of my speaking time just to read the title. And I think, in truth, we could simplify this. I think that the title could be, should we focus on relievers or controllers as we approach our patients with asthma? That's a fundamental question. What do you want your patients to be aware of, to be thinking about, to be focused on as you manage their asthma? I'll begin my talk momentarily. There's the customary disclosure slide. I'll zoom past that if I may. And here's what I'll talk about in this brief presentation. I want to talk about our treatment goals as we approach our patients with asthma. What do we aim for? How do we assess our outcomes? And as we have that in mind, the heart of the talk is about the traditional preventive asthma strategies and whether or not they've failed us. And then, of course, these newer treatment strategies. Are these something we should be rushing to adopt? I will get to a summary. I have some very strong opinions about this, as you may know, and I hope it gives you a moment to pause and think about your own patients and arrive at the right answer. Now, don't worry, I've just flashed the word pre-test on the screen. This is, of course, not a test. And although I'm going to pose some questions, medical school style, don't worry, I'm not going to do polling. I'm just going to ask you to think about what your answer might be to the following questions in the following, I hope, somewhat realistic scenarios. So let me ask you to imagine Sally. She's a young university student. She's been off to school. She's been diagnosed while she's been away at university by Student Health Services as having some asthma, presumably mild asthma. She's been given the ubiquitous blue inhaler, Ventolin, salbutamol, in the United States, albuterol, and she's used it. It worked. And now that she's home, she mentions that she's run out of her salbutamol over the last 3 months. She is, in fact, using this salbutamol for relief of not only daytime, but occasional nighttime symptoms. She asks for more of the same. So would you repeat the prescription? Option number A. Would you do this fancy new thing? Would you give her budesonide formoterol as the new reliever? Would you initiate a low-dose inhaled corticosteroid twice daily with a separate salbutamol reliever? Would you initiate a once-daily ICS LABA with a separate salbutamol reliever? Think about what you might actually do, and I'll move on to my next question. I'm stepping away from asthma. A middle-aged smoker. He smokes a pack per day. He's a return, if you will, repeat offender, and he's got this cough. It's no mystery to you why he has a cough. His spirometry is normal. His chest x-ray is normal. He's been tried on some inhaled therapies by various physicians. Nothing has worked. You've tried to get him to quit smoking, and he hasn't. So today, what would you do? Would you once again talk about smoking cessation? Or B, advise him to cut back a bit? Or C, just ignore the smoking behavior? Quick snap quiz back to asthma. Asthma symptom control, asthma exacerbations are separate treatment outcomes. True or false? And then finally, let's talk about this so-called MART or SMART therapy. In a patient maintained on maintenance and reliever therapy for 1 year, we would expect the following if we biopsy the airway, beginning and end. No change in airway eosinophil levels. A 25% reduction in airway eosinophil levels, a 50% reduction, a 75% reduction, or a doubling of airway eosinophil levels. The study's been done, by the way, and I'll show you the result. So let's start talking about treating a patient. I often refer to a typical patient in my practice, Ms. Weir. She's middle-aged, she's working, she's suffered from asthma for approximately 5 years. So this is later onset asthma, if we're keeping track. She's been referred by a primary practitioner in Canada. And the reason for referral is that she's been using a lot of her blue, her salbutamol quick reliever. In our practice, as your colleagues can attest, I am lazy, I sit back, I do nothing. My house staff will go in and speak to Ms. Weir and come back and say, yes, she is in fact using that quick reliever daily on average. This is despite being on an inhaled steroid twice a day. This is the older fluticasone propionate in low to moderate dosage twice daily. She awakens about once per week with an asthma symptom. She's had some prednisone for something that was called bronchitis. So she's had an asthma exacerbation in the past year, but she's not been hospitalized. She's not been in the emergency room. So we would ask a bit pedantically, is this lady's asthma controlled adequately? Yes, it is. No, it isn't, or don't know. And I'm glad that the majority of our trainees, in fact, the majority of our primary practitioners would recognize, if it's laid out this way, that Ms. Weir's asthma is not controlled to our contemporary standards. Now, we make this very easy for our trainees because as patients sit in the waiting room or in the examining room waiting to see us, we ask them to complete this questionnaire. You may recognize it's sponsored by Glaxo, the asthma control test. 5 questions. On each question, we ask the patient to look back at their asthma over the last 4 weeks and describe the outcome, the symptom burden, as being dreadful, that would be a low score of 1, or non-existent, a perfect score of 5. This allows us to cover the waterfront, as it were, to be thorough with each visit. We don't miss the question about nighttime symptoms or other symptoms. So we teach ourselves and our patients and our trainees to be thorough, and we get a nice numerical answer. Scores of 20 and above, the patient's disease appears to be well controlled. Lower than that, the disease is not well controlled. We need to fix something. And if the score is between 5 and 15, that is truly poor control. Now, where does this come from? Let's look for a moment at Ms. Weir, and I'll start to put some numbers to this. Her score, if we filled it in, might be 15. So this is in that very lowest category where we need to fix something. And we could place Ms. Weir on this observational study by Schatz and colleagues. They validated the meaning of the ACT questionnaire. In more than 2,000 patients, they administered the questionnaire and over the subsequent year kept track of the exacerbation outcome. What they found was as the scores dropped from a perfect 25 and fell below 20, the risk of having an exacerbation rose exponentially. And this is an important outcome, of course, in a couple of ways. One, it tells us of the importance of day-to-day symptoms. They do predict something with respect to the future, but it also tells us that exacerbations and symptoms are actually very closely linked. They're impossible to separate. Ms. Weir's score of 15 corresponds to an odds ratio down there in the bottom row of 1.6. In other words, her score suggests that she's 60% more likely to have an exacerbation in the coming year than patients whose score is 20 or above. A very simple little questionnaire to administer. There's the older ACQ. One of those should be part of every asthma encounter. I'm going to come back to that ACT questionnaire in a moment. I'm going to come back to the Schatz study, but let me move on to treatment. We have an evaluation. We have a patient, in the case of Ms. Weir, who's not adequately controlled. Let's talk about the treatments we have available. Now, forgive me, as has been suggested, I've been doing this for a while, and I'm going to haul out one of my old favorite slides, 2 airway biopsies. And we're going to come back to biopsies in a moment. But on the left, there's a biopsy that, if this were a medical school exam, you'd be forgiven for not recognizing. It's actually an airway epithelial biopsy, but it doesn't look like airway epithelium. Up there at the top where it says E, we should be seeing pseudocolumnar ciliated epithelium. It's not recognizable. BM is, of course, basement membrane. Below that, we see mucosa that is filled with nucleated, binucleated cells. Those are eosinophils. This is the biopsy of an airway full of eosinophilic inflammation. This is an asthma airway biopsy. Slide to the right. This is the one you needed to get right on the medical school exam. Up at the top, normal pseudocolumnar ciliated epithelium. Below the basement membrane, very few inflammatory cells. Same patient, by the way, and if you read the note at the bottom, this is 3 months of treatment with what was then a relatively new, what is now a very old inhaled steroid, budesonide, and it returns the airway to normal appearance and function. This became the foundation of asthma care approximately 3 decades ago. It tells us what we need to do for the vast majority of our patients with persistent symptoms, patients like Sally, that I introduced you to at the beginning, and patients like Ms. Weir. It's important, by the way, to recognize this persistence of symptoms and to implement this foundational therapy promptly. And here's a look at outcomes. It's going to be an outcome very familiar to pulmonary doctors. We like to measure what we're treating. Spirometry will give us a measurement of FEV1, and the y-axis is the improvement in FEV1 in percentage of patients with asthma treated with inhaled steroid. But we have 4 groups. The leftmost group had their treatment initiated promptly. Within 2 years of diagnosis, the improvement averaged 8%. 2 to 3 years, a little less, but close to that. But as treatment with optimal dosing is delayed, we see delayed treatment 3 to 5 years or more than 5 years. We have half the average improvability in FEV1. We get better results when we extinguish that airways inflammation early. We need to get to foundational cares early in the course of managing patients with asthma. So the question I asked in the outline for my talk is, well, do these traditional strategies work? And the answer is resoundingly yes. This has been a successful approach. We have people who want to throw out these approaches, these regular therapies, saying, no, they don't work anymore. So here is one of the founders of that regular preventive controller therapy movement. This is Terry Hatala. Look up his papers as they appeared in the 80s in the New England Journal of Medicine. But here are the data from the small country of Finland. They decided to implement regular preventive care in their population by making inhaled steroids readily available to all patients diagnosed with having asthma. Now, we have 4 things to track here from the beginning of that movement in the early 1980s to the turn of the millennium, and the data, by the way, continue to the present day. This rising line tells us that, like most Western nations, for reasons we could discuss in some other presentation, there are more asthma patients in Finland every year. Something about the Western lifestyle has led to this. This stable line running through the graph in the middle is the cost of inhaled controller therapy per patient. And as the controller therapy is given in regular preventive fashion, we see both death rates and hospitalizations due to asthma dropping. I will point out to you that people who espouse these clever new strategies will tell us that we're losing the fight against asthma, that there are patients out there dying because they aren't using budesonide formoterol reliever, except that it's not true anywhere where we see good statistics kept. And the rate of death from asthma in most developed nations is about the rate of deaths from being struck by lightning. I could show you the Canadian data. That's what it shows. But I know that there are attendees from a number of different countries. Please go look up your own data and see if there's an asthma death problem given our current regular treatment strategies. Here's another quick summary graph. It's Canadian. I must show it. It talks about this mortality reduction when we give inhaled corticosteroids. It's by Sami Suissa, Pierre Ernst, and others in the pharmacoepidemiologic group in Quebec, in Canada. And years ago, they said, we'd love to see our patients taking a low dose of inhaled corticosteroids, about a canister per month on a regular basis. And we see that if they do that, most of the time, the risk of death from asthma is low. And as you drop below about half of the prescribed doses, we see the risk of dying from asthma rises. This is a compelling graph, and I'm going to return to it later and talk about where some of the modern strategies might fit. So we've talked about giving regular therapy when there are persistent symptoms. Can we extinguish those symptoms? For Ms. Weir, for Sally, can we control asthma? I'm going to go back again, not quite so far, 2004, 2005, we heard about the GOAL study. At the time, it was a landmark study. It was 3,000 patients. It was the largest we'd seen in asthma. These were patients like Ms. Weir, not controlled by their current therapies, recruited to come in, and the investigators did something which, on this study design graph, looks a bit complicated, but what they did was a clinical job. They simply said, as we treat patients, we will ask if asthma is controlled. If it is, we will continue with whatever the patient is taking. If it is not, we will up the ante, we will increase the dosage. So here we have the study. Patients enter, there's some baseline data gathered, and at the first randomization point, patients either get inhaled fluticasone propionate, inhaled steroid monotherapy. This is old, this is twice a day. It's not very convenient, but there it is. Or they get a combination of ICS fluticasone and LABA, the old salmeterol, the first of the long-acting beta-agonist. We have better drugs today, but here it is. And the patients would take whatever they were randomized to for 3 months. That's the yellow bar. Now, here's the question. It's a simple clinical question. Are you controlled? Yes, in which case you continue. If you are not, you move up the dosage chain to the next higher dosage. Now, that was the study design at step 2, at step 3. And the question was, if we do this, if we administer the equivalent of an ACT score and adjust to get best control results, how often do we get those results by the end of the year? And the answer was in the vast majority of patients. Now, we could talk about the differences between ICS LABA and ICS. You get there a little bit better, more often and faster with the ICS LABA, but you also get there with the ICS monotherapy. And I'm not going to focus on that small difference today. What I'll point out is that you get there 80% of the time if you aim for control. By the way, the figure is probably closer to 90% if you ignore the lung function. Some of these patients had remodeled already. Remember that early graph. If you have a late start with controller therapy, you may see less than optimal lung function resulting. If you ignore the lung function result, the figure is closer to 90%. So why is it when we do studies out there in the broad community in just about any country you could name, only about 50% of patients are controlled? Well, we don't implement these strategies. Let's continue for a quick moment. Exacerbations are also outcomes that we look at, and I've pointed out that they're linked to symptoms. So in the GOAL study, where investigators aimed for best symptom control, the better outcome in 3 treatment groups, these were reflecting the background therapy, was always a little bit better when patients took the LABA mixed with their ICS, that is to say, lower exacerbation rates. But in both groups, ICS monotherapy and ICS LABA groups, as compared to baseline, as investigators aimed for best symptom control, the exacerbation rate was far lower than it had been at the baseline. So we know that if we aim for good symptom control, we're going to reduce exacerbations. Now, we've seen over the last 10 or 15 years, some clever people say, well, maybe we don't have to prevent the symptoms. It seems to work, but maybe not for everybody. What if we just let the symptoms happen and cleverly get there with something that contains both an ICS and a LABA that acts a bit quickly, a bit like salbutamol? So if you will, a reactive, a symptom-driven approach, and of course I'm describing so-called maintenance and reliever therapy. It was originally described as a small dose of ICS formoterol twice a day, and then doses of ICS formoterol as needed at the patient's discretion. Now, by the way, this ignores the question of patients who perceive their symptoms poorly. They're out there, the so-called poor perceivers. It also ignores the fact that we're giving patients 1 inhaler and 2 completely different sets of instructions. It shouldn't surprise us that patients often default to just taking their inhaler as needed, and we'll get to that in a moment. But let me jump past what people say and ask this question of my audience today. How many patients taking SMART therapy for 6 months to a year in good treatment centers, in investigator centers where doctors know how to administer SMART therapy, how many patients achieve control? The data I'm going to show you is actually from that company that espouses SMART therapy, and from the investigators who write papers about it and tell you it's a strategy to use. What's the answer? The answer comes from these 5 SMART trials. Again, all of them are sponsored by the same company. These were the trials that included enough control information for, at the time, the GINA guideline asthma control parameters to be applied. And it was published, the paper that did this analysis, in the Journal of Allergy and Clinical Immunology. The resulting answer was, in those SMART trials, 17%, fewer than 1 in 5 patients taking maintenance and reliever therapy achieved asthma control. 38% had only partial control, which, as you recall, means the treatment regimen needs to be fixed. And, by the way, 44% of patients were completely uncontrolled. This explains why in 2 large trials out in the community, SMART therapy has never been shown to do better than average community treatment. These are unpublished trials that are reported and buried in the company-sponsored website. I'll remind you that as we aim for control, we reduce exacerbations. This is the Schatz trial that I alluded to earlier. I just wanted to point out that if you have a terrible score, as low as 5 out of 25 on your ACT questionnaire, it means that you are having so many symptoms, most of us would call it an exacerbation. It says that in the last 4 weeks, asthma has prevented you from getting things done all of the time. It says that in the last 4 weeks, you've had shortness of breath most of the day. It says that you've been using reliever multiple times per day, and so on. In a word, low symptom scores on the ACT questionnaire are an exacerbation. These are not simply linked, they're the same thing. I'm going to ask you as well, and this harkens back to an earlier set of biopsies I showed you before. If we treat with smart therapy in expert centers for 1 year, and we biopsy airways at the beginning and the end, what happens to airways inflammation? It's not a hypothetical question. The study's been done, the results have been published. I'm sure they haven't been brought to your office. The study was sponsored by, well, you can guess which company, the company that espouses smart therapy, but hasn't shared this study result with you, and you'll see why in a moment. There were 2 treatment groups. Ignore the regular dosing, those patients improved. Let's just talk about what happened between baseline and 1 year of smart therapy with smart dosing. Total cell counts, no big change. Mast cells, no big change. CD4 positive lymphocytes, the numbers increased in smart treated patients. That's probably important. Most people don't keep track of CD4 positive lymphocytes. So let's slide to the right and look at something we all understand, eosinophils. The eosinophil count, and it's a significant difference, doubled from baseline in patients on smart therapy. It shouldn't be surprising. If we let the airway twitch, we are leaving it inflamed. Patients have increasing airways inflammation on a reliever-driven, on a symptom-driven approach that lets symptoms happen. Quiet airways are not inflamed airways. The latest iteration that builds on this is Sigma. Let me quickly review the Sigma data. People get impressed because it appeared in the New England Journal of Medicine. Remember, the prime mover for papers to be published in places like the New England Journal of Medicine and Lancet is that they are newsworthy, they're interesting, they catch our attention. Paul O'Byrne's description of Sigma-1 was to tell us the primary outcome, symptom control in 3 treatment groups, and here, over the course of the year, is the primary outcome of the Sigma-1 trial. Patients, well-controlled asthma weeks. Now, clearly there's a winner here. The patients assigned to the gray treatment have the best symptom control, the highest number of symptom control weeks quite consistently throughout the treatment year. And then there are 2 other almost identical outcomes. And the question is, well, what's the winner? And if you haven't looked at this paper lately and you're relying on what's trendy, you would say, well, my guess it must be Sigma. Budesonide formoterol is needed. That must be the winner because that's what's being recommended by the asthma experts. But you'd be wrong. It's old-fashioned regular inhaled corticosteroid. Not conveniently dosed once a day, but twice a day. Not dosed in a very high dose, a very low dose, but there it is, regular ICS therapy. The thing we've been doing for 30 plus years has been the winner. The budesonide formoterol is down there in the weeds next to terbutaline. Again, regular dosing, preventive dosing, and catch-up reliever-driven dosing. That's the outcome. This is the graph without my little arrow as it appeared in the New England Journal of Medicine, and yet we talk about Sigma-1 as if the clever new approach somehow worked. It didn't. Our strategy of preventing symptoms with controller therapy still worked better than the trendy new therapy. I will point out, by the way, that the investigators had done their best to set up regular ICS therapy as a loser. Having to take controller therapy twice daily or more is associated with lower adherence rates than taking inhaled steroid once daily. And as we all know, taking controller once daily is increasingly possible with newer molecules, and we see new additions to our armamentarium all the time. By the way, there was Sigma-2 very quickly. When Eric Bateman wrote the paper with colleagues, they talked about the underuse of inhaled glucocorticoids. They talked about asthma exacerbations and death. As I pointed out to you, this has been a decreasing problem over 30 years as we use a preventive strategy. They talked about poor adherence to maintenance therapy, and I would like to have seen them write that they were going to educate patients to use maintenance therapy. They didn't. They said more or less, well, let's trick patients into using a little bit of inhaled controller therapy, a little bit of ICS. So here were their results. I'll give you a moment. You're looking at that graph, probably going, wow, that's a lot of empty space there. You and I are accustomed to looking at asthma studies where exacerbations are happening, perhaps as much as once a year. That's the top of the y-axis here. In fact, in sigma 2, these were the exacerbation rates of the two treatment groups. There were hardly any exacerbations at all. I've cheated a little bit. This is the graph as it appeared in the New England Journal of Medicine, except in the New England Journal of Medicine, there was the inset with the y-axis expanded tenfold to magnify this non-exacerbation rate, so we could actually see it. This was a study in which exacerbations were the primary outcome, except that exacerbations weren't actually happening. In fact, this study, which was presented to us all as a non-inferiority study, was designed as a superiority study, implemented as a superiority study, and when it became clear that exacerbations weren't happening, was changed to a non-inferiority study. And on that basis, the investigators declared victory. They declared the two treatments as being identical, non-inferior, and that was nonsense. Let me show you that we've been here before. This is an older paper from the New England Journal of Medicine. It deals with pediatric asthma. It's got two markers of airways inflammation. On the left, exhaled nitric oxide, and of course, the higher the number, the more airways inflammation there is, interleukin-13 driven inflammation. On the right, sputum eosinophil counts, and of course, the higher they are, the more inflammation that is present. What's being compared? It's a year of treatment, intermittent treatment in the light blue columns, and we see exhaled nitric oxide levels rise, sputum eosinophils rise. Children treated with intermittent therapy suffer from more airways inflammation. Regular preventive asthma treatment is associated with a decrease in these inflammatory biomarkers. It's intuitive, it's obvious, we've been here before, and it applies if we talk about the intermittent strategies of SMART, and probably sigma, though that hasn't been well studied. Whoops. I was going to point out that if we look at the dose of inhaled corticosteroid that patients have received in the sigma trials, it is as low as where the red arrow is in this graph. In a word, the sigma trials will result in underdosing with inhaled corticosteroids in patients with persistent asthma. My colleagues who have espoused this, I think, began with a worthy goal. They wanted to see that as many patients as possible got at least some inhaled steroid. The risk now is that increasing numbers of patients who would have received traditional amounts of preventive therapy will now receive inadequate amounts of SMART and sigma dosing. Let me see if I can get to my next slide without a recording intervening. So if we look around the world at the way these intermittent strategies like sigma have been addressed, we discover they're not allowed in the United States, they're not allowed in Europe, they're not allowed in Canada for intermittent asthma. The Colombians, the Japanese, this is an older slide, but as regulatory agencies look dispassionately at the data for sigma, they say, no, that isn't a viable strategy. We're not going to approve it. So let me quickly go through my post-test, and then I'll get to a summary and we'll open for questions. Sally is a patient with persistent symptoms. She's newly diagnosed. I would like to think that we would make it easy for Sally and show her the best results. I would be tempted to give her a low-dose ICS LABA and to give her a separate reliever. If she came back with no symptoms and not having needed that little blue reliever, I would have succeeded, and I would like to see an ACT score of 25. A close second choice for me might be option number C. I don't think we should continue with reliever-driven approaches, and I'll point out that both A and B are reliever-driven approaches. The reason I included Jerry, the smoker, is to point out that we've learned not to compromise with smoking cessation. We all, from the specialist to the generalist to the nurse to the ward clerk, tell patients they need to stop smoking. As soon as we settle for second best, cut back on your smoking, we give patients permission to keep on smoking. I'm going to point out that we should not be settling for second best with the Sallys or the Ms. Weirs of this world. We should not let them play catch up with symptoms that are preventable the same way we don't settle for second best with smoking cessation. Asthma symptom control, asthma exacerbations, they're actually the same thing. Or if you prefer, they're very closely linked and inseparable. You cannot prevent asthma exacerbations if you don't prevent symptoms. And airway eosinophil levels, in case you were running off to get coffee when I showed the result. In expert asthma centers around the world, it's been published, it was published 10 years ago, smart treated patients will double the number of eosinophils in their airway epithelium. It is not a strategy that controls airways inflammation. So very quickly, exacerbation symptom control, at the very least, they're linked. You can't prevent exacerbations without preventing symptoms. If you want to let patients have symptoms and react to them, you're going to see increases in airways inflammation and airway instability. I think we should show patients the best results by preventing their symptoms as thoroughly as possible early on. And I think once daily strategies are becoming more and more the norm, we shouldn't be doing studies with twice daily preventive strategies in the mix. With that, I'll thank you and open up for questions.